whether that was of your own free will or of cajoling of sorts. Thank you either way. With us today, we have Lanre Omotayo, who has just joined us at UB as a postdoc, both with the community and in the School of Public Health and Health Professions. And so we're really excited to host you today, and we look forward to your talk.
Thank you so much. Well, I just want to echo Chris' word and say thank you for coming to listen at this time of the semester. I know it's pretty busy for every one of you. And this evening I'm going to be talking about preeclampsia in sub-Saharan Africa. Basically, I'm going to try to make the case that there is a need for us to reconsider what the research and programming agenda for preeclampsia in recent years has been, in the light of the evolution of the body of literature that looks at these diseases. Before I go into that, so like Coach just told you, I just joined the institution as a postdoctoral associate, and my interests are basically around, causes of death around the perinatal period and in very early pregnancy, in very early childhood. And I have a background in nutritional sciences, so I tend to treat towards things that have to do with nutrition. I love food a lot. But here today, I'm not going to be talking about food actually. I'm just going to be talking about preeclampsia. So, and basically, I'll be talking about, so why exactly should we care about preeclampsia? What's it that's so important for about preeclampsia for those of us who are working in global health? And for people, particularly people who are interested in, the survival of pregnant women towards the end of pregnancy and the survival of children in the first, in the very early part of their lives. So beyond that, I'm going to talk about what's been the focus of the research and the programming community. And by programming community, I'm talking about practitioners who work in different parts of the world to try to reduce mortality, to try to improve global health. And then I'll move on to what exactly, in the light of the recent literature, what exactly, and what we know about the situation of things in sub-Saharan Africa, what can we say about this focus, and should we stick to it, should we continue it, or should we be looking at a different agenda? Well, this is a pretty familiar picture for many people, and what it just shows what are the kind of things we think about when we think about the condition of preeclampsia. I mean, so what exactly is preeclampsia? Preeclampsia is a pregnancy-specific syndrome, meaning that it occurs only in pregnant women. I mean, you can find it outside that condition, and it's really characterized by elevated blood pressure and proteinuria. So when a woman who's not known to have hypertension prior to pregnancy, when that person suddenly starts to have elevated blood pressure in the second half of pregnancy, we know that physiologically, I mean the way the human body is programmed, during pregnancy the blood pressure actually falls over time as a result of a variety of physiological mechanisms. But in some women, the blood pressure just does not fall. When it gets to the second half of pregnancy, the blood pressure goes up. And then we make a diagnosis of hypertension in pregnancy. All around the world, there are different criteria about what constitutes an elevated blood pressure and what's not high enough to constitute elevated blood pressure. But irrespective of the cutoff, once we make, for that population, once the blood pressure goes beyond the threshold, we make a diagnosis of hypertension in pregnancy. Now, ideally, when you look at someone's urine, ideally you should not find proteins in people's urine, at least not detectable with the usual detectors that we use in the clinic. But when you use those dipsticks and you find protein to be positive in someone's urine, we make a diagnosis of proteinuria. So in a woman who's known to have hypertension in pregnancy, or who we diagnose of hypertension in pregnancy based on the blood pressure, if we find proteinuria also, now we make a diagnosis of preeclampsia. So essentially, it is hypertension coexisting with protein in the urine. Well, that's the way we diagnose preeclampsia. But that's not the entire story about preeclampsia. Because we know that there's a lot of other processes that underlie these two clinical features that we monitor. And these two features do not tell the whole story. You know, there's a lot of people who have blood pressure. There's a lot of people who have blood pressure, but what's peculiar about preeclampsia is that when you find out blood pressure and you find out proteinuria, you can expect that over time, that woman will progress to certain complications. One of those complications is what we call eclampsia, which is a situation where a woman who's been diagnosed with preeclampsia or who had preeclampsia suddenly develops seizures, develops generalized seizures. And for most obstetricians or people who've treated women in pregnancy, you realize that that's a nightmare of an obstetrician. Of course, it's a nightmare of a pregnant woman. That's something you don't want to see. Because about 50% of the women who go on to have eclampsia actually results in mortality. There's no single complication in pregnancy that has a case fatality rate that as high as that. Meaning that there's no complication that occurs in pregnancy that kills as many people who have that condition as eclampsia does. And that tells us that whether as a clinician or as a public health practitioner, if you're thinking about, if you're in a business of trying to save women from dying in the part of their pregnancy, that's not something you're going to be joking about. You have to really know your audience. You've got to be really serious about preeclampsia and its complications. So beyond high blood pressure, beyond the blood pressure, beyond proteinuria, some of the other signs and symptoms we look for is that women can have intractable headache, where you see a woman having too much, having a headache, who's having pain in the upper part of the stomach, who's having swellings in places where you shouldn't see swellings. I mean, there's some amount of swelling fetal swelling that comes with pregnancy, but we start seeing swelling in the hand, in the arm. When you start seeing swelling in the face, then you need to start thinking about whether you already have a complication on your hands. So I was talking about preeclampsia. So that's on the clinical level. But as public health practitioners, why do we care about this story actually? When you look at this set of graphs, they show us the cause-specific maternal mortality across the different regions of the world. One thing that you can see very clearly is that irrespective of where you go in the world, hypertension in pregnancy is a significant cause of maternal mortality. In places in Africa, 1 out of every 10 or 11 women that die in pregnancy is a sort of hypertension in pregnancy. If you go to places like South America, it can be as high as 20%, 1 out of 5 or 1 out of 4, depending on where you go. Even in the developed world, the only difference in the developed world is that not a lot of women, fortunately, not a lot of women die in pregnancy to start with. So even though, but out of the few that actually die in pregnancy, preeclampsia actually accounts for a good proportion. But that's not the whole story. The other part of the story is that if you had looked at this kind of graph, this graph is a 2013 graph. If you had looked at this set of graphs about 25 years before now, you would have seen a slightly different picture. It's still roughly the same thing, you still have roughly the same conditions, bleeding, hypertension in pregnancy, sepsis, abortion. These set of conditions have been accounting for about 75% of maternal mortality over time. But the distribution, the relative distribution among these different causes has been shifting. And what we've seen in the past 35 years is that, why the other causes, while the absolute contribution of the other causes has been going down, the other preeclampsia has not been going down, basically because the incidence and the case fatality, the number of people who die when they have the condition has just not been going anywhere. It's just static, while that for other causes has been going down. So when we talk about reduction in maternal mortality that has happened over time, reduction in preeclampsia mortality has almost contributed nothing to that process. And that's why a lot of people talk about the need to focus our efforts more on preeclampsia, but if we really want to deal with the scourge of maternal mortality. The problem of preeclampsia, the problem that preeclampsia poses for people who are interested in maternal mortality is well recognized. When you look at a lot of strategies, global strategies that talk about maternal mortality, preeclampsia takes a headline. But when people talk about child health, people in the child health community tend to have the attitude that, well, this is not our problem, it's a problem of people in maternal. But a couple of years ago, in 2015, Orji et al. Published these graphs, basically looking at the contribution of preeclampsia to stillbirth, early neonatal and late neonatal mortality. So the only way the problem with the way we've counted child deaths over time is that we've disregarded stillbirths. When you count stillbirths, you realize that preeclampsia contributes as much to child deaths as the first 3 to 4 causes of child mortality. Therefore, it's not just a problem for the maternal mortality community, but also a problem for anybody who's really serious about limiting the number of deaths that occur in the earliest periods in life. So, go ahead.
Do you mind interrupting?
No, absolutely not.
So that's really interesting to count the late fetal deaths and actually count sort of the in utero deaths as being a cause or caused by preeclampsia. Can you say specifically what preeclampsia will do to cause those deaths?
Yeah. So one of the things we know very well about preeclampsia is that basically preeclampsia alters the hemodynamics in the mother, and therefore it alters the availability of everything the baby needs from the mother. Because basically, fundamentally, preeclampsia is a condition of the placenta. And therefore what it does, on a very gross level, is distort the architecture, what's it called? It distorts the architecture of the blood vessels that actually connect the fetus to the mother. And for a very long time, it's been recognized that preeclampsia is a leading cause of intrauterine growth retardation. What's now been carefully counted is that a lot of times, when intrauterine growth retardation is actually precipitated by preeclampsia, the tendency to actually result in fetal loss is much higher than when IGR is actually precipitated by other causes like lack of adequate nutrition and most of the other causes. And that's why, and one of the things we know right now, there's still a lot we really don't understand about the pathophysiology. Right now we don't know the etiology, we don't know what triggers this whole process, and we don't really understand fully the molecular and pathological processes that result in this. But what we do know is that there's widespread alteration in the architecture of the blood vessels, and that severely limits the kind of nutrients that becomes available to the baby, to the fetus in that process. And a lot of times, fetal death occurs when we have this condition. Well, so, over time, there's been a lot of focus, like for many conditions that we know, there's been a lot of focus on unraveling the ethiopathology of preeclampsia. So a lot of the research and programming dollars, a lot of research dollars have gone into, well, let's just figure out what's causing this condition and what are the processes involved, and we might just be able to find a cure. And there's been the search for that silver bullet has gone on for so long a while. But what we do know, and that search has not been a search in futility, but what it's told us is that what we call preeclampsia essentially is a syndrome, and the underlying etiology does not seem to be just one condition. It seems to be a set of conditions that manifest clinically in the same common pathway. So the damage they cause appears similarly, and the way they lead to death, the way they lead to, the way those conditions lead to mortality, the way it leads to complications is through a common pathway. But the underlying etiology, what the summary of the literature and most of all the work that's been done in the last 2-3 decades is that there are so many theories, so many different things that contribute to this process that we don't think that this is just one etiological condition. The other thing is that, so the other avenue, the other way that people thought about this is that, well, if we can't figure out what the underlying cause, and we can't figure out a cure. Because we can't figure out a cure. Well, let's see what we can do so that when people have it, even if we cannot cure it, people can live with it, and we can keep on managing. Because one thing that we do know is that preeclampsia is a condition of the placenta. So as soon as you deliver the baby and the placenta is out, in like 97% of the cases, preeclampsia basically subsides. The symptoms disappear. So what you're trying, the rationale is, well, what can we do to help these women to remain alive and remain healthy until she delivers the baby? Because we know that once the baby is delivered, the problem is solved. But it's not as easy as that. Because the search for finding something that can actually help us manage those few weeks without risking the life of the mother has been has not yielded a lot of hits. So there's this slew of antihypertensives that are being used right now, because one of the initial theories was that, well, perhaps this is just, if we can manage hypertension, since we know that, one of the initial theories was that the hypertension, because of the hypertension and the hemodynamic, and the fact that the circulation, the maternal and fetal circulation and exchange plays a very huge role in the clinical outcomes we see. What if we can manage the mother's hypertension? And a lot of people, there's been a lot of money, a lot of time, a lot of effort and talent that's gone into finding that special antihypertensive that would work for women who have preeclampsia. Well, the story as of today is that we still use the common antihypertensives, even though they do not work as well as they would work in in people who are not, in people who have hypertension, not in pregnancy. But that's what we still use, and the results are still not satisfactory. The other approach that people have looked at is, well, we know that most of the people who die, or most of the mortality that is occasioned by preeclampsia, doesn't just happen when the woman has raisement in blood pressure or in the urine. It actually occurs when the woman progresses to eclampsia. That is when she develops the generalized seizure. Is there something we can do to slow the progression to eclampsia, such that if we're able to delay that, we might just be able to extend that delay until the woman delivers and interrupts the process, the pathological process. And there's been a lot of research that's gone into that, and it's been demonstrated, within the last decade, it's been demonstrated conclusively that magnesium sulfate can actually delay the progression from preeclampsia to eclampsia. And that has spurred, that almost entirely changed the programming agenda. A lot of people who are interested in working in communities, working in countries to limit, to address the burden of preeclampsia, basically just became magnesium sulfate advocates. The story became, let's just get magnesium sulfate to all the facilities in the countries, and the problem of preeclampsia, perhaps it's solved. But it turns out that that's a very, very optimistic scenario. Because these days we actually have a lot of magnesium sulfate being delivered to the communities. It works in a lot of cases, and it doesn't work in a lot of cases also. So we still have a lot of mortality due to preeclampsia, and there's still a lot of research that's going on to try to identify better antihypertensives. Drugs that will manage the blood pressure, better anticonvulsants, drugs that would prolong the period between the development of the clinical conditions and development of the complications, the seizure, the eclampsia. And a couple of years ago, Goldenberg et al. They reviewed a lot of literature that had to do with preeclampsia. And one of the insights that came out of that process is that, well, the incidence and case fatality of preeclampsia had not always been like this in North America and in Europe. The decline in incidence and case fatality of preeclampsia, actually, it was a very steep decline from 1940 to 1970 that led to the disparity in the incidence and case fatality distribution that we see across the world today. And what can we learn from what happened in Europe and North America. And one of the things they were able to show that about 90% of the decline is almost completely attributable to the fact that women came to the health facilities a lot more, and they had access to a particular set of services, emergency services. So as soon as a woman, when a woman has preeclampsia, one of the things the standard management is for us to wait and see, and monitor very carefully until if you pick any sign that tells you that this woman might go into convulsion, that's what you try to prevent. Then what you do is just deliver the baby. But another time we do that, whether or not the baby is ready to actually come to the world, whether the baby is fit to live at that point. So what happened in Europe and North America, and Golden Period at all, is that a lot of the facilities that were around were actually equipped in such a way that almost every woman who had this condition had somewhere to rush to if there were signs that she would go into a seizure, or even when a seizure had occurred, and those facilities were ready to just deliver the woman right and there and interrupt the process. And that's how we have that decline that we have today, and that's how the situation has been over time. And this publication also shifted the focus of a lot of people in the programming community to thinking about, well, maybe what we should do in places like Africa is, let's just get all the magnesium software to all those places, and let's just build theaters in all the facilities that we can find in sub-Saharan Africa. And so one of the concerns that people raised was that, wait a minute. So if we do that, what it means is that we're going to be delivering babies that would have come to the world in a different way by themselves. We're going to have a lot of interventions to deliver babies, whether they're cesarean sections or it's the use of other kinds of instrumentation. And then Lisopova et al. Looked at, they looked at ecological data from Europe and North America again, from the period between 1995 and 2005. And what they were able to tell us is that, that's a period that is well known to have been a period when neonatal mortality even decreased further in those regions of the world. And what they've been able to show is that, the incidence of iatrogenic deliveries, that deliveries that have to do with cesarean section or some kind of instrumentation, was actually increasing steadily in those countries over that period of time. But despite that, what we saw was a decline in neonatal mortality. Of course, every student in EP 101 knows that this is ecological data. I mean, this tells us nothing about whether the people who are having the cesarean sections are not actually dying. They might be dying, subsets of the population might be surviving and might be overcompensating for the deaths we're seeing from the increased iatrogenic deaths. But that's not a question that's been answered. But what I want us to look at is that, well, as the community shifts to the focus on building theaters and providing emergency delivery services, what does that mean? What are the implications for people who are interested in programming in sub-Saharan Africa? There are some key features, what we know about sub-Saharan Africa. What would this mean? One of the things we know about sub-Saharan Africa is that sub-Saharan Africa is different from the 1940s Europe. Sub-Saharan Africa is not, the situation there is not just a situation of Europe or North America in its primitive years. No, it's different in very significant ways. Europe and North America, even as of 1940, had healthcare facilities that at the stage of the birth, facilities for managing preterm births. So what essentially happened is that when a woman rushes to the healthcare clinic, even if she has to be delivered at the 37th week or at the 36th week, they can deliver the baby and still take care of the baby if it's not too early. Of course, they did not, the facility were not as sophisticated as what they have today, and they would not deal with very early preterms. But a significant proportion of the women who get delivered due to preeclampsia actually get delivered between the 34th and the 37th week. But what we know in sub-Saharan Africa is that when babies get delivered during that period of time, they don't necessarily survive. Even though a lot of trials have shown that there are interventions that, when adequately delivered, can save the life of babies that are born during that period of time. Researchers have consistently shown that in sub-Saharan Africa, those things don't get done. Whether you're talking about sophisticated things or the simple things. So if we're shifting our attention to emergency services to address the burden of preeclampsia, we need to think about the fact that we should anticipate an epidemic of iatrogenic deliveries, if you would put it that way. And any strategy that's going to rely on emergency delivery has to think about how do we ensure that that does not lead to, that we're basically not substituting maternal mortality, with neonatal mortality. The other thing we know, we know about the nature of the health system in sub-Saharan Africa is that in a lot of places outside the cities, what you have, these are the kind of health facilities that we have. In a sense, these are health facilities that, to take them from the state they are right now to the state where they will be able to deliver the kind of services we're thinking about, it's a lot of money, it's a lot of resources. We need to think about, is that the best, given all we know about this field today, is that the best use of resources to save the life of women that would occur due to preeclampsia? And I'll tell you why, one of the other options we have that we might want to think about. The other thing we know about these healthcare facilities is that the cadre of the healthcare workers who work in these places is so varied and so different from what we had in 1940 Europe and North America. A lot of the people who work in these places are, well, there's a very wide range of, there's a very wide cadre. But in many of these places, there are people who, even when you're able to build a theater and you're able to equip it, there are now people that you can, it will be hard to get the existing manpower to be able to utilize those theaters in many of these places. Right now, we don't even have the theaters yet. What we have is a lot of magnesium sulfate, a lot of drugs that can be used. One of the main problems we have right now is that a lot of people who work in these kind of facilities are not using those drugs well. They're not using those drugs well. If those drugs are being used the way they're meant to be used, from what we know from the clinical trials, we should have seen what the trajectory, the decline of mortality due to preeclampsia should not look like what it's looking right now. So perhaps theaters might not be the next priority. So another development in the literature related to preeclampsia in the last couple of years is that for about 30 years, from 1960, this is 2000, well, that's about 50 years, there's been series of trials and studies and cohort studies and clinical trials trying to figure out, well, even if we're not able to figure out what's the underlying fact, what causes this. I mean, there's been a lot of situations where we're not able to work out the underlying pathology, but we stumbled on some kind of drug that works, or some kind of preventive medicine that works. Why don't we just try our hands on a lot of things from the kind of observations we have? And one of the things that's been in the literature for a long time is a report by Hamlin et al. I mean, these were researchers in Europe who went to work in Ethiopia. And one of the things they observed is that, despite the fact that a lot of people were having preeclampsia in so many places, there's this part of Ethiopia where people were not having that disease. And so they tried to understand what were the differences between these two, this community and other places. And one of the things they hypothesized was that the diet in these communities was starkly different from what we had in most other parts of Ethiopia. And they had the hypothesis that there might be something about diet that plays a role in this whole process, even though we don't know how this might come back. And that has spurred a lot of cohort studies, a lot of clinical trials over time. But the results have been really mixed. But in 2011, starting from 2008 to 2011, there's been a series of meta-analyses, and the meta-analyses were able to demonstrate that actually, if you look at these data, if you actually synthesize this data, what it should be telling us is that just some items in the diet that actually prevent preeclampsia. Specifically, Omotayo et al. Were able to demonstrate that in populations with low habitual calcium intake, when you supplement with calcium, about 30% to 40% of the cases of preeclampsia are prevented. And that led to the recommendation from the nutrition expert group of the WHO. So given all this, given the issues about the current agenda about theaters and emergency healthcare services, what we know about preventive measures at this point, what we know about differences in the current situation in the 1940 to 1970 Europe and North America, and what we know about sub-Saharan Africa today, where should we be putting our research and programming dollars and efforts? And I think that there's no silver bullet to deal with the preeclampsia problem at this point. What we can only think about is to think about an integrated and comprehensive strategy, which of course still takes into cognizance the progress that Europe recorded and North America recorded, and we should still think about how to improve case management. But primary prevention is an integral part of any comprehensive strategy that's going to be addressing the problem of preeclampsia in a place like sub-Saharan Africa. Paying attention to the manpower in terms of how they deal with specific issues, in terms of the skills that are needed to handle case management and to handle other aspects of preeclampsia prevention, whether primary or secondary prevention, is an important component of any strategy. Of any strategy that would carefully consider what we know about the evolution of the literature that pertains to preeclampsia at this point. So in essence, preeclampsia is an important problem for anybody who's interested in global health, particularly maternal mortality and neonatal mortality at this period of time as we move into the era of the SDGs. And the global research focus traditionally has been on understanding the ethiopathology and case management. And at this point, we think that even though emphasis on the historical decline in Europe and North America is useful, it's important to know, but it's not sufficient. An integrated approach that takes into cognizance the need for primary prevention, the need to be realistic about the differences in the health systems in sub-Saharan Africa today and 1940s Europe and North America, and the limitations of preterm management in sub-Saharan Africa today is important. Thank you.
This is where we open it up for discussion, questions, observations.
Go ahead.
So you said primary prevention is one key way, and I walked out of the room as you were bringing up the information about calcium. Was it that calcium can help reduce incidence of preeclampsia in women? Or was it, I missed that part, I just wanted you to read.
Well, yeah, so a couple of meta-analyses have shown between 2011 and 2013 that in populations where calcium intake is very low, when you supplement women with calcium, about 30 to 40% of the cases of preeclampsia in those communities can be prevented. Of course, there's still a lot of issues about what exactly does that mean in terms of implementing that kind of policy. But I do think that trying to resolve those issues and trying to really understand what exactly do these findings mean? It's an important way for us to spend our research efforts and dollars at this point in time, in addition to the current emphasis on improving case management. So and one of the things we do know is that, yes, calcium supplementation is not, there's a number of studies that did not show any effect, raising the issue that it just doesn't work everywhere, and we don't really understand that process completely. And of course, the fact that we're not able to make a very clear case at the level of pathophysiology also limits the kind of confidence we have in this. But what we do know from the epidemiology studies that when the trials are conducted in places where it is established that there is habitual calcium intake less than 500 milligrams per day, time and time again, we see an effect in preeclampsia prevention in the clinical trials. Go ahead, please.
So I have a question that may be complex, but so in the world of nutrition, for nutrition interventions, there are these trends, and so in the 80s and 90s, people were interested in single nutrient supplementation to prevent all sorts of things in young children, from stunting to mental deficits. And those single nutrient types of approaches then went to multiple nutrients, and then are all of a sudden at, we need to be looking at food and food systems. And we need to be thinking about, we know that some of these approaches actually do work, but we need to figure out how to scale them up, because from efficacy trials to effectiveness trials, we see that they don't work very well. So in this, there's a lot of differences that I think you very nicely pointed out between sub-Saharan Africa and what works in sort of developed countries even 60 years ago. But do you think that this promise of single nutrients, or such as calcium or magnesium sulfate, are we going to find out maybe 10 to 20 years from now that we need to be doing something more complex, or because the single thing is not working, or is it a matter of we need to train people correctly so that it can be scaled up and it will be effective in the field? What's your feeling?
The thing is, I think it's going to be irresponsible for me to rule out that we're going to find something that works better, or find out that, this maybe wasn't working as we thought it was going to work some 20 years down the line. I cannot say that. I can say that, this is a literature that's been going on for 50 years, and, looking at the design of the studies, the nature of the studies, there's reasonable confidence in this. But even then, I still subscribe to the idea that, perhaps what all these studies still tell us, that there's no substitute for a well-fed woman in pregnancy. If a woman is eating what she has to eat, that's perhaps the ultimate solution to a lot of the problems that we're having. So, what we can, what I've just spoken about is looking at things on a very broad level. Some of the work that we did in Kenya was essentially trying to understand that beyond these silver bullet things, is there a way that the community, people just by the way they live in their community, can actually eat their own foods in such a way that they're able to actually just meet their calcium requirements. Essentially, are people able, is there something we can do to make people have a balanced diet? And ultimately, I still think that's the way to go. But also, I think that we don't necessarily have to say that, if that's not happening right now, let's just not supplement as a matter of principle. I don't think that, that's not the principle I would subscribe to, but I would think that the ultimate way to go is to just still know what I think this whole literature, whether on the calcium supplementation or the iron supplementation or whichever of the supplementation, what I think the whole literature still tells us ultimately is that people need to be able to get the balanced diet. We have to find a way around that. Does that? Go ahead.
A simple question and then reciprocal, more complicated question maybe.
Okay.
Simple question first. When and where was preeclampsia first named?
When and where it was first named. That's not a very simple one.
Do you want somebody to look it up?
Yeah,
Sure.
let me get your phone out.
So while somebody finds that information, I'll describe why I asked that,
Okay.
and into the more complicated one. While we do that, could you go back to the diagram? Please.
This?
Diagram. Yeah, that one there. So, because my training is as an architect and not in the arena of public health,
Okay.
when I look at diagrams like this, I look at them in a couple of different ways.
Okay.
One of the ways I look at them is in terms of the white space, not the boxes.
Okay.
So what that suggests to me is there's room for more boxes. Okay, very simply stated. The reason I asked the question about the origin of the term is one of the comments you made is there seem to be a series of different or combined causes that lead to preeclampsia. Suggests to me maybe we're holding on to a particular name and the history of a name, even though it might be much more diversified than that, which suggests right now everything points to one box, but that should probably be a bit more multiple. And there may be other boxes that are hidden that we're not seeing because in some ways our language and the history of the discipline and people looking at this might be looking at it through a particular history and set of terms and language. And could it be opened up to be looked at in a different way?
That's an absolutely fantastic insight, and I absolutely agree with you because after every decade, since the 1940s, 1950s, after every decade, we come up with a set of theories and a set of empirical findings that matches up that theory very closely, that people are able to declare, oh, it looks like the end of preeclampsia is so much in sight. And then all of a sudden it looks like, well, maybe not. That's just one pathway. And that's the way we've gone on from decade after decade until, the last series of studies that the NIH has just funded that's been able to identify a series of very interesting biomarkers. So, that in itself tells us that the incremental approach with which we've approached this set of issues and the focus on the ethiopathology, there's probably a lot of other boxes that we should be looking at. But what are those boxes? That I think is the real question at this point. What are those boxes and we should be looking at them? Is not something that's really clear at this point.
Answer.
So answer, the first known description of the condition was by Hippocrates. In
Wow.
5th century, 5th century BC.
Okay.
Yeah. So pretty outdated.
Thank you for that.
Yeah.
Could be, but one thing we still know right now though is, so, the way we conceptualize, there might be a lot of problems about the way we conceptualize it. Because what we do right now, basically, preeclampsia is conceptualized in a syndromic way right now. So what we do is wait for a terminal event. What we're looking at is hypertension. It's a terminal event. The hypertension looking at proteinuria. There's a lot of, it's very clear that the process has been going on right from very early in pregnancy. That's very clear to us. That the process that apparently manifests in the hypertension we see actually starts much earlier in pregnancy, as early as the 7-8 week. So we know very little about what happens in that intervening period, and we just look at what happens at the end because we know that, because we feel like what happens at the end is what actually leads to mortality. Go ahead.
So this is a question that may have just popped into my head and may have nothing to do. But there's actually quite a lot of sort of very early miscarriages that happen in women, and I don't know if anybody has studied this. but you know, one idea is that, you know, very early miscarriages are probably a good thing in that they take, good thing quote unquote, because they probably take care of a lot of really serious problems or problems that would have developed into something very serious had the pregnancy gone on. And so it's sort of a, you know, almost a protective factor of sorts. I don't know, has anybody looked at sort of, probably not, because it's too early, but whether there's any similarities to some of the, perhaps the biomarkers that you've mentioned in these very early or early miscarriages and preeclampsia, and I just don't know, it just popped into my head, and I wonder whether there's any, whether these preeclamptic pregnancies share some common biomarkers or factors to early miscarriages, and whether they had gone on.
Particularly if you're looking at the same women
but
presenting with both
conditions. So they weren't serious enough to abort early, but are showing sort of early signs of distress and problems. I don't know.
Yeah, I'm not aware of any literature that's looked at that. But I know people have looked at a range of other things, you know. So one thing that we do know is that what really happens a lot of time is that the blood vessels that move from the mother to the baby just get destroyed in so many other ways. There are other conditions that also have blood vessels. You know, there's a range of placental abnormalities that present that way also. But you know, they seem to be very they seem to be very different from preeclampsia if you accept the way a lot of people think about preeclampsia, you know. So, because one of the very huge debates right now, it's whether the pathophysiology changes that we're calling preeclampsia itself. I mean, are those things, you know, tied together enough? You know, can we explain them by a coherent set of processes enough for us to say that we even have a syndrome on our hands at all? And that's a very huge debate. So, but if we ignore that debate and say that there's something called preeclampsia, then those series of, what we call preeclampsia right now, seems to be pretty distinct from other, you know, other placental abnormalities that tend to present that way also.
So having had 2 children and gone through actually pretty extensive education before birth, I would have known nothing regarding like what I should be eating at certain stages of pregnancy. I would have known nothing regarding, you know, what is preeclampsia, or even am I at risk for it, had I not had that education. And so I'm wondering, in your experiences in Kenya or other places in sub-Saharan Africa, where is education coming from? Is it coming from mothers and elders in the community, midwives? Is it coming from community health workers? And if it's not there, do women seek it out elsewhere? Just kind of getting a feel for that.
I mean, that's a complex question to be frank, because you know there's a lot of disparity in where women actually access their information. So one of the things we did in our formative research in Kenya was to actually talk to women. You know, but when you look at women in the rural areas, a lot of time people get their information about pregnancy from the elderly women in their families or in the communities. Even though there's a lot of push right now to be able to get the health system to move deeper into the communities through community health workers. So even though there's a facility, there are community health workers that are linked to the facility who go to the communities and try to interact with the elderly women in those communities so that whatever they pass on to the younger women who are in childbearing age would be good information. But the very simple answer to that is that it depends. It really depends, because there's a lot of places in rural Kenya where people don't, you know, women don't even listen to mass media. They don't go to the health facilities. They just interact with people in their families and people in their communities, And on the other hand, you have places like Kisumu, places like Nairobi, or places like Lagos, where pretty much it's just part of being a denizen of that region to watch the television, to listen to the radio, to to interact with some kind of health facility, irrespective of what kind of health facility it is. So there's a geographical disparity. There's also a very huge socioeconomic disparity in where people actually access the information they have about their, not just pregnancy, but about their health altogether.
We have time for one more. Okay, thank you very much.
Thank you so much.
Biplop, can I put you on the spot to give a pitch for your talk tomorrow?
Can we talk tomorrow? Okay.
Yeah.
And next week.
And next week, yeah, two double pitch.
Yeah. Hi everyone. I'm Biplop Bhattacharya. I'm a PhD student with Industrial and Systems Engineering, and I work primarily with pharmaceutical supply chains in low resource countries. And I'm giving two talks, as Corey just mentioned, over the next 1 week. One being tomorrow at 129 Hochschild Hall on North Campus. I don't know if I'm pronouncing that right though. At noon. And the other is the Global Health Dialogue over here next week, same time, same place. Tomorrow I will be focusing more on an engineering perspective and talk more about the mathematical formulations behind what I do, as well as my experience in Uganda. To take 2 steps back, in August, as a partnership of this office with LinkedIn Health Access Initiative, I traveled to Uganda for a week and a half to work on a couple of projects. So I'll be talking about that, my own research, and the challenges that exist right now in the pharmaceutical supply chain, and how we can help as industrial engineers. So that's kind of the topic. And for next week, it'll be more of a discussion-based conversation where I will put out some questions and we will hopefully have an engaging discussion. So yeah, thank you.
Great. Thank you. If you haven't signed in,